Good morning and welcome to the symposium. Today I'm going to describe a study to examine the effects of smoking, comorbidities, and race ethnicity on SARS coronavirus 2 infection. This research was supported by the Tobacco-Related Disease Research Program Emergency COVID-19 funding. I don't have any competing interest to report. The reason why I'm recording my virtual presentation for the SRNT annual meeting this year, instead of presenting in front of you, is because of COVID-19 pandemic. Everyone is affected, but not equally. While increasing evidence suggests that the elderly, racial ethnic minorities, and those with certain comorbidities are at significantly higher risk of adverse outcomes from COVID-19. There are still a lot of unknowns around what impacts COVID-19 infection. Smoking is a particularly concerning health behavior because it suppresses immune function in the lungs, forces the exhalations of significant quantities and high concentrations of droplet particles, and impacts the amount of contact people may have with contaminated surfaces. For example, from contaminated hands touching the cigarette and the cigarettes touching lips, which may increase the risk of lung infection. Additionally, individuals regularly exposed to secondhand smoke, known as passive smokers, may face similar respiratory problems and immune system effects as smokers, and therefore an increased likelihood of COVID-19 infection. In light of these gaps, we aim to explore the differences between lab-confirmed COVID-19 positive and negative cases to identify risk factors for testing positive for SARS coronavirus 2, and to understand whether active or passive smoking, comorbidities, or race ethnicity contribute independently to predisposition of COVID-19 infection, which could guide efforts aimed at minimizing these disparities for COVID-19. We hypothesize that racial and ethnic minority patients who are active or passive smokers and have more severe comorbidities are more likely than other patients to be lab-confirmed COVID-19 positive cases. The study setting was Sutter Health, a not-for-profit organization serving over 100 communities in Northern and Central California. Sutter Health providers served more than 3 million patients who represent diverse groups of social demographic and cultural backgrounds. Sutter Health's electronic health record system, EPIC, is deployed across the enterprise in all three settings. Patients were included in the study sample if they visited primary care providers, had contact with and suspected exposure to SARS coronavirus 2, and have a SARS coronavirus 2 test performed at a Sutter Health facility between February 20th and July 26, 2020. There was no exclusion criteria based on age. A total of 9,104 patients were identified. COVID-19 confirmed cases are defined as having one or more positive tests for SARS coronavirus 2. The comparison group included patients whose COVID-19 lab test results were all negative. Using electronic health records, we obtained the prior exposure of patients in each group, focusing on smoking habits, severity of comorbidities, and the race ethnicity. Chi-square tests were used for testing the differences between lab-confirmed COVID-19 positive and negative cases. Variables were then assessed as potential independent predictors using multivariable logistic regression. In our study sample, there were 407 patients who tested positive for SARS coronavirus 2. The majority were female and have no major comorbidities. Mean age was 44 years old. Non-Hispanic whites made up less than half of the sample, while non-Hispanic Asians Hispanic and Latinos, and the non-Hispanic Blacks made up 18%, 15%, and 3% of the sample respectively. Of our sample, nearly 6% were current smokers, 20% former smokers, and nearly 1% were passive smokers. A quarter of the smokers reported that they were light smokers with fewer than 10 pack years smoking history, while 10% of the smokers were heavy smokers with over 20 pack years smoking history. Only 4% of all patients used smokeless tobacco. There are significant differences in sex, age, race, ethnicity, smoking status when comparing lab-confirmed SARS coronavirus 2 positive and negative cases. As you can see from this slide, patients younger than 18 years old were less likely than adults to be lab-confirmed positive. Males, Hispanic or Latino patients, and patients with moderate comorbidities were more likely to be lab-confirmed positive cases. Passive smokers were more likely than non-smokers to be lab-confirmed positive. But no statistically significant difference were found when comparing current smokers or former smokers with non-smokers. Our findings suggest that passive smokers, but not current smokers, are more likely to be lab-confirmed SARS coronavirus 2 positive. The possible reason for the higher odds of being SARS coronavirus 2 positive among passive smokers, but not active smokers, remain unclear. However, when smokers exhale, they are intentionally and forcefully pushing air out of their lungs. The deliberate, deep exhalation of tobacco smoke expels large quantity and high concentration of particles. The massive rush of particulate matter may provide opportunities for viral particles to be expelled from the lung and transmitted to the passive smokers. Consequently, secondhand smoke deposit on surfaces and in dust to become third-hand smoke residue. Viral particles and droplets with viral particles also deposit on surfaces and in dust. So third-hand smoke may affect the survival of SARS coronavirus 2 on surfaces and in dust. Additionally, selection bias may skew the results because smokers are more likely to experience respiratory symptoms, including cough, expectoration, and the sore throat, which could lead to more frequent testing and increasing proportion of smokers with negative SARS coronavirus 2 results. Previous studies suggested that COVID-19 has affected more adults than children and more men than women. We found a similar increased risk of a positive SARS coronavirus 2 test in patients above 18 years old and in men. We also found that Hispanic Latino patients had 3.7 times the odds of a positive SARS coronavirus 2 test result than non-Hispanic white patients, which remained significant after adjusting for smoking status, age, sex, and comorbidities. Consistent with previous studies, this finding highlights the disproportionate incidence of COVID-19 among the Hispanic population. Employment in high-risk positions, education, income, and the structural barrier to health are all factors likely contribute to this association. We also found an association between severity of major comorbidities and a positive SARS coronavirus 2 test as hypothesized. Specifically, patients with moderate comorbidities were about 1.7 times as likely to have the disease as those without comorbidities. We acknowledge several limitations in the current study. The study population only included individuals who were assessed for SARS coronavirus 2 infection by a physician and were tested for SARS coronavirus 2. Thus, results only reflect risk factors for testing positive for SARS coronavirus 2. We limited our study sample to patients visiting primary care providers, as the level of missingness of smoking status was too high among patients receiving care in an emergency department, and the primary care providers generally have more time to document the patient's smoking status and the comorbidities, which allows us to identify risk factors for SARS coronavirus 2 infection. This may have also removed very severe COVID-19 cases, as these patients were likely to go directly to an emergency department. Even with this limitation, however, we were able to detect differences among groups with regard to the variables of interest. There are limitations in the diagnostic tests used and the sensitivity and the specificity of the test themselves. In our sample, many patients have several simultaneous or repeated tests, which could overcome an individual test's limited sensitivity. Although barriers to documentation of smoking status for patients tested for SARS coronavirus 2 at emergency departments needs to be better understood, the completeness, sensitivity, and the positive predictive values of smoking history documentation in the EHR have improved considerably in recent years, indicating that EHR is an acceptable source for identifying patients with a history of smoking for research in primary care, similar to our study population. However, the measurement of some smoking behaviors, such as duration of smoking, age at which patients first smoked, type of tobacco smoked, level of smoking, and passive smoking, are limited by the available data and may be underreported in the EHR. More comprehensive assessment of secondhand smoke exposure and the biological confirmation are required to better understand potential biases in reported exposure and the conditions under which secondhand smoke may affect COVID-19 transmission, infection, symptoms, and health outcomes. Our findings suggest that passive smokers, as well as old patients, males, patients identifying as Hispanic, Latino, and patients with more severe comorbidities are at increased risk for test positive for SARS coronavirus 2. Federal, state, and the local government should dedicate the resources necessary to comprehensively support these particularly vulnerable populations during COVID-19 pandemic. This should include, but not be limited to, protecting non-smokers from exposure to secondhand smoke. Findings from the study would be useful in identifying the critical individual characteristics that should be considered in tailoring approaches to identify trusted sources of information and create effective messaging to disseminate COVID-19 prevention and control information. Additional research is also needed to improve documentation of smoking history, pack years, vaping, and secondhand exposure, especially among patients tested for SARS coronavirus 2 at emergency departments. Future studies should investigate the risk of severe outcomes among active and passive smokers, the role that exposure to tobacco smoke constitutes among non-smokers, the role of comorbidities in COVID-19 disease course, and the health disparities experienced by disadvantaged groups. Thank you very much.